So I think that, we had a big burst of activity in the early part of this millennia, and a number of new agents were approved, and so there was a decade of research that was spent trying to sort through that and decide what might be the optimal therapy for patients with colon cancer. What's the best chemotherapy to use? What's the best biologic agent to use? And in the midst of that time, we understood that there were some molecular features that could help us perhaps predict or use them as a biomarker to try to optimize regimens for a particular form of colon cancer in a patient. And so the most widely used is RAS testing, which everybody's pretty familiar with, I would imagine. We now understand that BRAF alterations and HER2 alterations might also specify certain therapies for patients. And I think the very exciting field of checkpoint inhibitors is still evolving, and we're trying to understand where those fit in the world of colon cancer therapy. But in terms of what I'm going to be talking about, optimizing first-line therapy, I think some of the important points are that it's pretty clear that chemotherapy doublets and a biologic are pretty standard as a first-line therapy. What's clear is that there's a number of options, and there's not necessarily a one best option. It's becoming more and more clear that the sidedness of the primary tumor may help to predict which regimen we would use insofar as a biologic agent. So the EGFR agents don't seem to perhaps provide as much benefit for patients who have a right-sided primary tumor. And so we see that those are used more commonly in patients with left-sided primaries.